Welcome back to the Global Virtual Sun meeting. I hope you enjoyed the first part. During the second half of this meeting, we'll learn about how healthcare providers, assisted by the armed forces and others, were able to quickly establish temporary hospitals and how simulation was used to help. We'll hear about cases from emergency hospitals set up in conference centers throughout the UK to enable the National Health Service to prepare for the expected tsunami of COVID-19 patients. We'll learn how simulation was used as a tool to prepare personnel to cope with the unprecedented situation and to train staff quickly and efficiently. We will also hear about how hospitals and health personnel in the greater New York area tried to cope with similar challenges. The New York area was especially overwhelmed by the number of COVID-19 patients. We will learn how they tried to handle the crisis, how they train, and how they continue to cope today.
Good morning again, everyone. Broadcasting here from New York, where we're having a beautiful sunny day. Hope it's a beautiful sunny day where you are. We're about to introduce our guests from Stony Brook University Medical Center. Before that, I think we just have a few brief housekeeping details that we'd like to go over, and I'll just wait for those to come up on the screen. We're also waiting for our guests to join us. There we go. Before we start, all attendees will be muted, but you will have an opportunity to answer questions or to ask questions. So we invite you, please, to use Zoom's Q&A function to raise your hand, ask a question. We are doing our utmost to make sure that we reserve some time for our presenters to be able to answer those questions for you at the end of their presentation. So recordings, we are recording today's webinars, and we will be mailing you a link so that you can view these again in the future. And just so you understand, I am speaking in English, and this event today is being presented in English. So, so thank you. Why don't we advance forward, please? I'll introduce myself. I'm Andrew Christopik. I'm the Senior Content Marketing Manager at Laerdal, and I'm going to use this as an opportunity to give a shout out to our team who creates our content and helps deliver it to you. We invite everyone here viewing today to go online to our website and subscribe to our content so that we can provide you the information, data, and resources that will help you be successful in simulation. Thank you. So our next guests will be talking about training in a post-COVID world looking forward. Thankfully, we've flattened the curve here in the States, and we're coming out of at least the initial impact of COVID-19. So our guests will be talking about recommendations, not only their experience, but recommendations for simulation training as it relates to a pandemic or an emergency situation in the future. So welcome, Stony Brook University Medical Center. Thank you very much. I'm going to introduce our guests in just a moment, but I'd like to talk a little bit about Stony Brook University Medical Center. Congratulations to all of you for celebrating your 40th anniversary. On Sunday, this past Sunday, Stony Brook celebrated their very first 2 patients that were treated there, and it's been a great history since, and a very interesting history, both due to your passion for medicine, your passion for saving lives, and improving outcomes. Also, your location. Your location has put you at the epicenter of some major events, including 9/11. Stony Brook is the first hospital and at least on Long Island, maintains the only medical monitoring and treatment program for first responders and other respondents to the 9/11 tragedy. Stony Brook is also named as one of America's 100 best hospitals by Health Grades. So congratulations to all of you. Why don't I introduce our presenters? So first we have Dr. Mark Henry. Mark Henry has been wonderful in working with us and assembling a team to be able to speak this morning. He is professor and chairman at Stony Brook Medicine for the Department of Emergency Medicine. Next, we have Alison Rowe, who is the Associate Director of Nursing for Emergency and Cardiac Services at Stony Brook. Then we have Andrew Wackett, Vice Dean of Undergraduate Medical Education and Director of Clinical Simulation there at the Simulation Center, and also Clinical Associate Professor of Emergency Medicine there at Stony Brook. And lastly, Eric Morley, Associate Professor and Clinical Director at the Department of Emergency Medicine. So thank you all for joining us this morning, and very, very much appreciate all the effort you've put into being here as a group. So we're going to launch in with the very first question, and for those viewing, we're going to handle this as an interview. So the first question we'll send out to Mark, but Mark, you lead your team and how you'd like to respond. So Stony Brook was hit pretty hard in terms of the influx of patients. Did you think that COVID-19 was coming your way? We know that you did a lot of research in advance and you were on top of this. Why don't you explain what happened at Stony Brook, what your experience was?
Well, we first took notice of the events in Wuhan. I personally had been to Wuhan, spoke at a medical center there about 15 years ago. They have sophisticated medical care. So when things were out of control in Wuhan, China, it wasn't like some backwater place that what's going on there. It got all our attention. And, we prepare for influenza-like illness on a regular basis. We have reports every 8 hours coming out from Triage. And this was another case where travel history was suddenly added. So did you have ILI symptoms plus you came from Wuhan? Then it was, did you come from China? Then was it from Asia? And, we got our alerts up in January from the CDC and the Department of Health to start screening location-based. Testing was limited, but we had our ears to the ground. And around February 8th, Dr. Morley started with Alison Rowe, they started a patient under investigation tag in our electronic record so we could keep track of the patients who we were worried about. And then, as happens with exponential spread from infections, it just blew up, and the numbers just increased dramatically in a short period of time.
So maybe we could actually take a look at that. You sent us some data, and we're bringing it up on the screen now. So this is what the curve looked like there at Stony Brook, and you're approximately how many? You're approximately 45 minutes from New York City.
We're a little over an hour, but
depends on traffic, right?
We're in a commutable, area, Suffolk County, where we're based.
Sure.
Many people commute to the city for work, so of course we're attuned to what's going on there. And what you're looking at here are the number of visits that we sent to a forward triage and treatment area outside the emergency department, and because we reserved the ER for the critical people. And this is where you can see it exploded. These are other people who had influenza-like illness, and we were suspecting them as COVID positive. And you can see how the numbers just blew up. And we were lucky to have an offsite. Eric and Allison, you were part of setting this whole thing up. and seeing people in these settings. You maybe want to explain to them more.
Right. So, I think what's important when you talk about what we were expecting, when you look at that curve, you could really see that we started off with very few patients on March 9th. And this was a really, I think, important decision and a lot of conversation that Alison and I probably could, remember quite a bit of it with the organization, a lot of leadership. We basically had to decide if we were going to divert patients from the entrance of the emergency department to go to a secondary treatment area. And at that time, we weren't really seeing many patients, and trying to get that information from, about 40 miles away from the city, they were starting to see an uptick. And we had to make that decision to really change our entire operation. And you can see on March 9th, 10th, we saw 9 patients, then 11 patients, then 18 patients, and it sort of exploded within about a week. And I think we opened up that area just in time. And I think one of the things that is important for people to realize is we have without pediatrics, a 67-bed ED, with pediatrics, about 77 beds. And, the normal social distancing that's allowed or not allowed during non-COVID times, we really had to make sure we had space for these patients when they came in. And so when we hit our peak on March 30th of 154 patients that we saw in that treatment area, we would not have survived. We would have had patients shoulder to shoulder in the waiting room, cohabitating in rooms, and we had to avoid that. And one of the successes, we managed to avoid that throughout the entire, and to this day, and managed to avoid co-locating patients in the same room. And we've had no more than 3 patients in the waiting room since this started. And I think that was a huge success for the organization. We were also lucky in that we had a couple things happening leading up to COVID. We opened a new inpatient tower in January that allowed us to have some open space. And we were able to utilize some of that space to create a forward triage area. We'll talk in a few slides about our tent, which is another unique experience. But at the beginning phase, from the 9th to the 23rd, we were able to use sort of an abandoned outpatient area to set up 20 beds for these patients. But we were also lucky that during that lead up to this, we had developed a throughput office that basically imagined how we do the bedding process and how we assign patients to different floors, and that proved to be really critical in a disaster type of way. Well, in helping for disaster responses went through. So I think getting to that original question, were we preparing for this that lead up to March 9th? I think that was a critical time when we really felt the surge was coming, and we pretty quickly, within a couple of days, set up this alternate area to see patients. And that proved, I think, to be in the end sort of life-saving for us, to keep patients from being on top of each other in the waiting room.
Sure. So that's a good segue to our next question. And that has to do with what changes you had to make in order to cope, because even though you had the benefit of some extra space, you really had to bob and weave, improvise, adapt, overcome, and scramble all at the same time. So we've got some photos from you that explain your experience. So why don't you please go ahead and walk through those? Maybe we could just go back one slide, please.
Go back to that one slide.
Yep.
So I'll go through some of the initial stuff, and then Alison, I think you'll talk about the sicker patients and the inpatient side and what we had to do with the ICUs. But again, going back, the model was get the less sick patients, the patients that were more ambulatory, that needed testing, were maybe borderline, and get them to this forward treatment area so that we could separate out the sickest patients from the less sick patients, and just maintain social distancing and have a place to see these patients. And so we included this slide to give you the scope. We basically got this tent from New York State and had help with the National Guard, the Department of Environmental Conservation, the DOH, to put this up essentially overnight. But as I said, we started in an abandoned outpatient unit from March 9th to March 23rd. The reason we left that unit was not because that wasn't acceptable anymore. It was that the hospital was planning to expand inpatient services to more places within the hospital. And the plan was to potentially utilize that space we were in as another inpatient unit. So we got a call on a Saturday night that we needed to move out. And we started making plans on this Sunday morning of the 22nd. And by the 24th, we were actually fully operational in this tent, and saw about 100 patients that day within about a 36-hour time period. We got that rolled out, and as you can imagine, required resources from IT, from pharmacy, from all different folks to sort of do something we've never done before. And you can go to the next slide. So you can see the slide we're on now gives you a good perspective of the size. It was basically 4 units that were about 50 feet in length. And this is what they looked like when we showed up on Sunday night. This is going to be our new home. You can go to the next slide. And this is really what it came down to. And being a simulation, conference here, I would have loved the opportunity to spend hours doing tabletop exercises and figuring out, and maybe in the future we will do more of that to sort of say, how do we plan for something like this? But we had a few hours to get this up and running, and I think this is Alison's handwriting here. She actually insisted that we needed a little diagram like this, and so on the fly we sort of just created our new world.
It worked, right?
It worked, it did. And I think one of the key components through all this is we planted ourselves, ED leadership, in the process, basically 18 hours a day. And we did rapid cycle improvement. We changed things every hour until we got it right. And that was a sort of a key ingredient when you don't have the time to simulate maybe ahead of time. This was an essential ingredient. You go to the next slide. And so, you could look at this is our entrance, and you can see the triage suite, as we like to call it, at the back. And in the front here, you have our waiting room. So we set up our chairs to socially distance patients. And then we had our triage corner up in the front. You can go to the next slide. And then this is what it looked like. You had a direct track to walk straight through if you needed to. And each treatment chair basically was about 6 feet apart, separated by curtains. You can go to the next slide. We actually built a small radiology area for doing our chest x-rays because we knew that would be an essential part of the workup for most of these patients. And this was a challenge. We had to get all the regulatory components met, that were radiation safety and that we weren't exposing people to unnecessary radiation. And so that was an interesting challenge we had to overcome. And then we, of course, needed a clean area where you can see behind that staff only sign where we could allow people to take breaks and take off their PPE and maintain safety for staff during all this. So it was a challenge, and I think it was quite successful. As I said, on our peak day, we saw about 154 patients in this tent, and that would have completely overrun us if we had not had that in place. And I'll turn it over to Alison. I think that's the last of our slides. I'll turn it over to Alison to sort of talk about the other side of this, where we had just this incredible burden of ICU patients, and that required an amazing response from the hospital that Alison could speak more to.
Thank you for having us. So as Dr. Morley said, we had the opportunity to be able to have some decanted space. So we had some decanted space after opening a new bed tower that we had not reused for a different purpose. So we were able to push in fairly quickly into some of those old spaces. If you can imagine what we needed to do in a tent, we needed to do that exponentially in these leftover ICUs and leftover units. So every unit needed computers, every unit needed monitors, Zols, resuscitation carts, and nurses. We redeployed a lot of our staff, many of our physician staff, many of our mid-levels, and many of our nurses that were no longer at the bedside, but we needed them to help manage our additional ICUs. At one point, we had well over 100 ICU patients, probably tipping somewhere around 120 plus. We opened at our peak over 6 ICUs, which were about 15 to 20 beds each. So the amount of capacity that we created at Stony Brook was huge. And like I said, when you ask the question is, what changed? What did we have to do on the fly? The answer is pretty much everything. So everything from staffing plans to flow patterns, which really saved the emergency department, that we were able to create the additional space. So when I talk about additional ICU beds, we also created additional step-down beds and additional med-surg beds. All of that helped to make sure that our patients were able to be socially distanced, make sure our positive patients were cohorted with other positive patients, make sure that our patients that were still under investigation had their own private space. And our history at Stony Brook is that we are well known for our hallway protocol for overcrowding. So that actually had to pretty much immediately stop. So we couldn't put patients in our hallways. Once this started going on, obviously we wanted to protect our patients and our staff. So creating this additional space through what our CTO, our centralized throughput office, really helped to make sure that we had the space that we needed.
Great, thank you, Allison. So everything changed. Let's go to our next question, which is, if it's possible to prioritize, if it's possible to sort it all out, and there's a second part to this question, what clinical training areas proved essential? And I'd like to actually divide this question into two parts. What clinical training areas proved essential on the front end? And all right, so there's a suggestion here that airway was probably one of them, but also on the back end, we're hearing from a lot of clients that extubation, for example, and trach care now are a key part of the training agenda as we're coming down off the curve. But I'll let you all please comment on what clinical training areas proved mission critical.
So I think we found that you're right. On the front end, the intubation was certainly critical, and we found ourselves doing this in a very different way. We had to be cognizant of the protection of ourselves and our staff, limiting the number of clinicians that would be around the bedside when we were intubating, making sure we had the proper equipment at that time, and also considering the contamination of the equipment we'd use. So we had to do things like place bags over our monitor scopes. We had to limit our interaction with the patient's oropharynx, making sure we were not getting terribly close to it. That was some of the big changes. Communication, teamwork, those also became huge issues as well. And I think simulation could really be used to help train that. I had wished we had more time ahead of time to use simulation. Unfortunately, we had to do many of these skills on the fly. But given the chance to repeat such a thing, we would have spent a lot more time practicing that.
The communication becomes now doubly critical when you can't even read people's body language. Right now, it's I can't understand if your expression is expressing concern. I can't see that now. When of course people in surgery deal with that all the time naturally, but for many people it was probably a new concept. So Drew, we're going to be hearing a lot from you as we go forward with some of these next questions, but of course everyone please chime in. How would you, now that you've been through this experience, so you were really thrown in as a team playing a new game, and really having to cope with learning the rules of the game on the fly, and the rules changed a lot as I'm sure as you went through the experience. How would you use simulation to prepare for this again?
I mean, I think there are several ways to use it. You know, what usually comes forth as the obvious way is teaching the skills of the initial resuscitation. And that's definitely important. You know, learning how to do intubations in this unique setting, considering how to place central venous access lines in this very specific situation. But I think even more important than that is learning the communication amongst the different members. You know, how physicians, nurses, consultants, respiratory therapists, radiology technicians are all going to interact. It's a very different scenario when not everyone can be in the room and you may have to communicate from outside the room. And also, it's a novel virus, so we don't know much about it. And we often have to change our treatment strategies on the fly based on how each patient interacts. So just learning how to interact with the care team to maybe alter the way we would typically practice things is a very great opportunity for the simulation setting, especially as you consider how you would debrief after something.
Sure. So debriefing, now I'm sure that you were doing debriefing on the fly with just as you handled each case, is there anything you learned from debriefing with those cases as you were doing rapid cycle improvement that you would want to bring over to debriefing in a simulation environment?
I think one of the unique examples that we had in this pandemic that we haven't really dealt with to this much of an extent is trying to have that end of life conversation. You know, it's a tough thing to hear, but there are definitely situations where nobody benefits from additional healthcare. Intubating patients whose likelihood of survival is dismally low. It's not going to be a good end of life for them, and it's very dangerous for the staff and uses up very, very precious resources. So those are difficult conversations to have. We found ourselves trying to make those decisions on the fly, and really would have been a much easier opportunity if we had had the chance to practice through some of those conversations through simulation.
And I think Alison brought up some good points when we were talking yesterday, that you had to fast track a lot of people into this environment, and many of them are new, and having to have those discussions. Alison, I'll turn it right over to you if you'd like to comment.
Yeah, I mean, I would say, like Dr. Wackett said, that these conversations are difficult to have with patients and families outside of COVID. And it became incredibly important to be able to understand the wishes of our patients and their families, and to be able to understand that our teams were very mixed. So some of our teams, we had a very senior ICU attending with a fairly junior ICU nurse, or even a redeployed ICU nurse and a mid-level that didn't typically work in this environment, and vice versa. Sometimes the nurse was the senior member of the team, helping to lead the discussion about continued efforts. What did the family say that they wanted? What does the patient want? And, you know, have we sort of exhausted our efforts with this patient? And was everybody comfortable understanding that we don't typically work with these team members, that we are done with this code, that everybody feels that we gave the patient our best effort, and sort of call for any last recommendations before we unfortunately call the code. And I think that was really important, both debriefing at the end, but also during the code, that everybody within that team, it's easy because I talk to, I work with Dr. Wackett every day, I work with Dr. Morley every day. We have a comfort level being able to speak up if we feel like something hasn't been done for our patient, or we should stop because this is not the wishes of our patient. That becomes increasingly challenging when we work with members of the team that we're not always so familiar with. So that in the moment debriefing was critical to the staff success and the staff comfort and our patients.
Excellent. Thank you. Oh, please, no.
Yeah, no, I think something that was a little maybe underappreciated, maybe not underappreciated, but something I certainly felt was the cognitive load and the stress it adds when you need to don just this very unusual set of PPE and multiple layers of PPE, and how do you put this on right? And I think I was part of some resuscitations where, I think that added to a stress level that made the actual function of taking care of a critically ill patient much more difficult. And I think simulation, for the sake of PPE, is actually a place where we could benefit. I don't know if Drew, Mark, or Alison have thoughts on that as well, but to me that was a particularly stressful thing that I watched roll out several times.
That's a good lead into our next question, Andrew. I think you were about to answer, and it falls right in line with our next question. And we don't have to necessarily focus on scenarios. The question is, what scenarios would you advise simulationists listening to focus on? And okay, so I'm going to tee it up to you and maybe talk about that cognitive load and simulating stress. In the States, we talk about stress inoculation training or stress endurance training. If you'd like to comment on that, but also comment on any other scenarios that you would advise people focus on going forward.
Yeah, I think Eric brought up a great point. And once you start to introduce the fact that you have to put on this very complicated PPE equipment to protect yourself, something that you're not used to doing on a day-to-day basis, and then dealing with the complexity of the medical situation. It's a lot to take in. Furthermore, to add a difficult social situation where you're trying to negotiate with the family as to whether this is the right pathway to take this patient on. It's overwhelming. So to break it down and to practice the first of all, just donning and doffing the PPE in a simulation center over and over again, it makes it second nature to you. So that becomes a reflex. You can move on and then spend more of your time concentrating on the complexities of the medical case at hand. You could also practice those particular scenarios. You could practice the communication skills, and suddenly it becomes a much more routine, situation.
I would also add that, you know, something as basic as putting on an N95 mask and taking it off without infecting yourself, or, you know, doing it correctly. I think a lot of us take it for, you know, just, we don't really think about how critical that is, especially for something like this. I mean, obviously we all wear our N95s primarily for TB, and that sort of concern is not exactly there. So taking it off correctly became something that we needed to share videos with to our staff to make sure that they were doing it correctly. And the number of staff that I needed to stop along the way to say, you know, look at what you're doing. You're, you know, you need to take it off differently. You need to pay attention. You need to wash your hands before and after, those sort of things. Something basic like that becomes something that would really benefit from making sure that the staff can demonstrate to you, simulate to you, you know, before all of this is going on. You know, taking on and off a gown without it going all over your scrubs at the same time became something that we learned. I mean, we did a lot of simulation with Ebola, right? Because we were concerned significantly about the donning and doffing. And we definitely needed to pull upon some of those experiences of the practice that we had with those, with our gowns going on and off, as well as our N95s.
So would you recommend that people chunk their simulations so that you're doing component parts before it all gets put together as a puzzle? It sounds like that's where you might be going with how you would recommend people compose their simulations for this kind of an event in the future.
I think that is the way you have to do it. It's so complicated that you really have to break it down into its parts, master each section of it, and then put all those pieces together to make sure that they can function.
So back to the scenarios you might recommend. Were there, we're not looking for the clinical pathway and all the steps and so forth, but were there certain clinical areas where, maybe another way to rephrase the question is, was there anything that surprised you where you said, aha, in the future we better create a scenario for this because we were either lacking or people were maybe no longer skilled in a particular area, not familiar anymore with a certain area?
Well, with respect to the split flow, you know, that's a challenge in itself because you've said ahead of time that you think this patient is not as sick as the one who needs a critical bed right away, potentially dischargeable home. But if you're not set up to deal with all these worried people who are ill in an expeditious manner, panic can set in. And part of the health system is to mitigate scenarios like this, to give confidence that, yeah, we are on top of it. So as Eric said, I mean, he and Alison made sure things were perfect by rapid recycling, by being present as they set up the new areas. But when we were putting 100 more people through in one shift through the tent, the turnaround time was about 28 minutes per patient, which is incredible. But that means everybody's working in sync. You know, the triage people there, the nursing, the mid-levels, the attending physician, the radiology techs. It was really amazing to watch. And I think it gave people confidence that we were on top of that part of the game. Now, in the beginning, and even now, this, you know, we're a health science center. We train nursing students, medical students, dental students, physician assistants. They were told, avoid the COVID patients. We didn't want to expose the students. But when these scenarios, these young people may someday be the caregiver, and it could happen fast. So there's a role for simulation in the very tasks that they're not asked to participate in as a student, so that they are prepared, because you have to be ready to be redeployed.
So I'll conclude from that, if I'm summarizing correctly, that it would be good to have a mass involvement simulation. I hate to use the word catastrophe, but that is the word, or a mass response simulation, so that people can at least get a taste of what it's going to mean for that total coordination, total collaboration.
Yeah, we do this with disaster drills in hospitals.
Sure.
I mean, that's, you know, you're supposed to run disaster drills, which is the same thing. A sudden influx of people all at one time. How do you respond?
Right.
Okay, so here's a novel situation where there's a particular disease that's going to be around for a while, and it makes sense that people prepare themselves for this, because you don't know where it's going to hit, you know, but it certainly has that potential. And the fear, as always with epidemics, is they can explode and overwhelm the health system.
Very good. Thank you, Doctor. So we'll turn to our next question, which, and we don't need to spend much time on it, but it's still a critical topic when you're bringing all these people together that, as Alison said, you're accustomed to working together, but all of a sudden you've got people thrown together that aren't necessarily familiar with each other. How can interdisciplinary team training help? That's a hot topic in simulation, but it often seems like to many a soft skill, when in reality it's a pretty hardcore skill. I'll dealer's choice, whoever wants to answer that one. I'm looking at you, Andrew, right now. Maybe you want to answer that one, but anyone, what's your opinion?
Yeah, I think it's the hardest skill, honestly, communication. I mean, anyone with enough practice can learn to do a particular procedure on a patient, but it's that communication and interaction amongst other team members that makes it the hardest. And that is something that I think we struggled with in many of these cases. And the simulation environment is the perfect way to tease out some of those things, you know, look at what a difficult interaction looks like, and then debrief and talk about better ways to handle that afterwards. And you really need to bring all the different members of the healthcare team into that. And that's not always easy, but when you work amongst those other members, you'll really see some of those differences come out, and it gives you lots of good fodder for the debriefing session.
Sure. And a statistic that we often talk to is that 70% of patient harm has its connection to a breakdown in communications and teamwork. So it's important.
I would also
go ahead, please,
if
Alison.
I could, I would also add that, you know, it's critically important that everybody understands, you know, their role in the process, and only interdisciplinary training can help make that happen. So a lot of what we do sort of relies on the person before us doing their job, right? So the doctor can't take care of the patient until the nurse triages the patient. The nurse can't triage the patient until I have a set of vital signs on the patient. You know, radiology can't shoot the x-ray unless there's a weight entered, or we can't discharge a patient until, you know, the education is in. All these sort of things just rely on each other, really everybody fulfilling their role completely. And like Dr. Henry said, being able to see this number of patients in such a short amount of time really relies on everybody understanding their role, being trained well up to their role. And what we did every shift, and Dr. Morley did it more than anybody else, was an immediate debrief prior to the start of the shift. So everybody knew coming into these areas, they got an orientation to that area. This is what we do. This is how we do it here. This is why we do it. This is what you need to do. And each person had their specific roles. So the nurses, you know, had specific roles, our LPNs, our techs, our physicians, and that was critical. So, you know, it relied on that success and that throughput, and the timely care of our patients really relied on everybody understanding what the expectations were. And like I said, a lot of that happened in real-time debriefing prior to the start of our shift. And like I said, Dr. Morley probably did 99% of it, but it was critical to make sure that everybody was moving in the same direction.
Yeah, I want to add to that, because while we've said things happen on the fly, it wasn't like everyone was creating on the fly. It was Dr. Morley and Alison were, like, you know, setting the standard for what we expected people to do and getting it right, because we didn't want variation in activities by individuals. So that was a very important step. And we, you know, we also put our research division into making a cohort of these people under investigation, because it was a new illness. We weren't sure how it was going to turn out. And we used those numbers to help us predict the number of intubations that were going to happen, the number of ICU beds that would be needed. And we also had, in addition to the incident command structure for the hospital, which has been going on now almost 90 days, we had our team, our emergency department team, meet every day at 10:30 for an orientation. What's going right? What's the vibe going to look like today? What about tomorrow? And so we kept in constant contact that way.
Excellent. Thank you, Doctor.
Please go ahead.
Oh,
sorry. To bring back to one SIM component of this, I think one of the things that I have the most pride in our department is I think the nurses and physicians work extremely well together in our department, so much so that our codes in a lot of ways are nurse run, and the physicians, you know, sort of are there to sort of go through the differential diagnosis and whatnot. And we function really well together as a team. But one of the things that COVID introduced was a completely new way of doing business. And when you have a really cohesive team that's used to doing things really well and actually communicate extraordinarily well, in my opinion, and all of a sudden you change the rules, that is actually, I think, even more difficult than bringing together team members who don't know each other and get given a new set of rules, right? So that sort of dance that goes on in the resuscitation bay, I think, works really well for us. And when you change the rules, though, and limit the number of people that are allowed in and who does what and how those roles change, I think that is a huge opportunity when there's, and that I probably underappreciated for SIM would be to sort of, when you have a change in those roles, how do you train at least the leaders to be able to go out there and teach people how the new process works. So I think that's a big opportunity.
That's a great point, because training for change, right? Murphy's Law, training for Murphy's Law. All of a sudden someone's plucked out of the equation, or someone's not available, or a piece of equipment doesn't work. That's something we've worked into our own workshops in the past. So point well taken. We're going to transition over to some audience questions, and I've got one here that's, I think, is a question on everybody's mind. How do we go back to normal training, and is there such a thing as normal training anymore? And why don't we begin with you on that, Andrew? But we can go around the whole group for that one.
I mean, we're already planning that. So we're starting to bring, the residents have always been training, all of the faculty has been training, but we had to take a period of time where our medical students weren't allowed to be on the clinical services because of the lack of PPE. We're now just starting to transition them back in, and we're starting to think about things like, can we open up the clinical simulation center? At what capacity do we open it up? And I think it's important to open it. I think that we can do it safely with people entering wearing masks, with us preserving social distancing when we can, being very astute about hand washing and cleaning the equipment after it's used. So I think it can be done, and it's important that we start getting back to that training again.
So, yeah, and I just to add to that, I think there's no such thing as, you know, what getting back to normal. I think we just have to accept the world is what it is now, and be innovative and seek ways to do things better. You know, for example, all these meetings that we're on around the world right now, that this technology existed before COVID, yet I think many of us, in this time I've given lectures to large audiences, I've had meetings from you know, in ways that we never would have had before. And we're reinventing the way we run our department, and actually now have several opportunities to get people more included than they ever were before because of some of the new technology that we just didn't utilize before. And I think the way forward is to look at your situation and the problems that you have, and actually understand they're not going to go away. And right now we have flow problems that are worse than ever because we have very few COVID patients, right? But we have to find ways to have essentially two hospitals function, one COVID, one non-COVID. But I think the only way forward is to accept that it's not going to come back to normal anytime soon, and to find the innovative ways to actually maybe make things better than they were before. And that's I think you won't get through this without that kind of attitude. That's my, you know, not specific advice, but sort of an approach.
I'm sure many would say you're spot on. And before I continue, I just want to make sure that there's no one else that wanted to respond to that question. So I will continue. What in your training agenda, what have you discovered you can live without, and what have you discovered you absolutely need going forward? We've all discovered things that we thought we relied on, and we've learned that, oh, we can do without it. And then there's some things I can't imagine us reversing course on.
I can give one example of
Sure.
something we did early on when we were really in the height of the virus load in our area. We still held simulation activities, but we did it in a very different way. We had a sim tech in the room, wearing a mask, wearing gloves, wearing a gown, and then we had our students on Zoom platforms. So they would work together, and they would be able to see what was going on with the patient, what the vital sign changes were, and make decisions based on that. So they still reaped a lot of the benefits of the simulation activities without being unsafe and having them present there in the room. So there's very creative ways that you can keep training even under the worst of situations.
Sure. Anything else from the group? So I want to come back to just one other topic, and that was the cognitive load topic. So a study came out of one of the EDs in New York City that stress can reduce someone's performance during a code by as much as 25%. Are you following, I'm not sure if Stony Brook's doing any training in this regard during your simulations or not, but are you following any of the research or literature that's coming out on stress reduction training, sort of stress immunization training to, you mentioned when people put on their PPE, they already start to get stressed, right? Their heart starts to race. So I'm just wondering if you're doing anything in the training or simulation program to help people understand how to cope with stress, how to accept it as part of the routine drill.
We have talked about that. We have looked at that research, and we definitely incorporate that into our simulation activities. A lot of it through the debriefing portion of it, but we've also simply found that through repetition, your stress level goes down. As you become more and more comfortable with those situations, you're not as stressed about it because you start to have some expectations.
Okay, great. So thank you. We're gonna go to one closing comment. You all definitely had a vision, and that vision was mission success. Even though the conditions changed every day, you didn't change the goal, and you kept plowing forward. So we're going to leave this quote up here: train with a sense of urgency so you don't have to act like it's an emergency. I'll let you all have some final remarks, please, on this quote and your
Well,
ability to be mission oriented through all of this. Go ahead, Mark.
I think this is the mission of emergency medicine. You know, emergency medicine deals with disasters. It deals with mass casualties. That's part of what we do. You know, it's required training by Joint Commission of Hospitals. We undertake that kind of training. And, you know, we had a big wake up here with 9/11 in New York. So, I mean, the role of medicine changed there in terms of mitigation of mass casualties, whether they be explosive or chemical or radiological or biological. And there's storehouses of antidotes and antibiotics and ventilators around the country as a result of, you know, actions people took because of that. So it's part of what we do. And, you know, as a medical center, I mentioned that we undertook to learn more about the disease, and we shared our experience early with others to advise them. And the title of the correspondence in New England Journal that we sent in was "Staying Ahead of the Wave." And I mean, that would be my advice to people with this COVID, because it's not over.
Thank you, Doctor. Drew, would you like to comment?
Yeah, I think that, you know, there are times through this pandemic that all of us woke up and would have our moments where we couldn't believe this was happening to us, and it's real difficult. But I think that the mantra really was that we've been through tough times before. We can handle this. We can take it one day at a time and adapt to whatever comes our way. I mean, really, that's the attitude you need. We can handle this.
Excellent. Alison, any comments?
Yeah, I mean, I would also say that I think that we had the best buy-in from our staff. Our staff were eager for information. Our staff were eager for the rules of the road. They wanted to know what should they be doing, when should they be doing it, how should they be doing it, to make sure that they understood the expectations that we had on them, and we were giving them the tools in order to do their job. So I would say that, you know, we, like Dr. Henry said, we do a lot of disaster drills. We're required to do them from our regulatory agencies, but as well as we understand that as a medical center, we would be the first people to receive many critically ill patients, regardless of the, you know, the mode of why they are sick. And I think this is going to help the most as with the buy-in, that this can happen to us. This did happen to us. This is happening to all of us. And it's both personal and professional, to every person that works at Stony Brook, to every person in our community, that we are in this. And we need to make sure that we have a plan right now and going forward. And training is a huge portion and part of how to make sure that that happens now and going into our future.
Great. Thank you, Alison. Eric.
Yes. So just a couple quick things. I think first and foremost, I'm incredibly grateful to the team that I got to work with through a lot of this, both nursing, physician, even hospital leadership. And I think the sense of relying on that team to do amazing work is a key ingredient to getting through anything like this. And so I'm incredibly grateful for that. The second thing is the thing I'll take for the rest of my career is never get your feet stuck in the concrete, sort of, and sort of not be able to adapt and change. And every few hours you may need to adapt and to just, you know, get everybody on board, sort of to what Alison was saying on that. These things are coming fast and furious. We're going to change. We're going to do it together. We're going to play by the rules, and we're going to just get this done, because that's what we do. And that sort of was an amazing experience going through this, that I'll probably take for an approach to sort of a lot of the things I face in the future. So it was an incredible learning event. We have an incredible team, and that was an amazing thing to be a part of and to still be a part of. So that's what I take from it.
Excellent. Thank you. Well, thank you all, Mark, Drew, Alison, Eric. You're all an inspiration, as is the entire team at Stony Brook. When I reached out to you, Mark. We had talked a little bit about your schedule, and when we finally talked, it was your first moment of at least having some peacetime after 72 days of being on duty. And I know that all of you have shared in that. You've really carried the load. So it's been an inspiring experience and a humbling experience. Thank you for all your knowledge and wisdom that you've shared today. Thank you.
Thank you.
Thank you, Andrew.
Thank you.
Thank you. Thank you very much, Andrew, and also to the team from Stony Brook University Hospital. It's been very interesting to listen what you had to say, and also to the team from UK last hour before that. So this has been a great day, Andrew. I mean,
it has, absolutely.
We have never done something like this before.
And
I think one thing we want to take home message for us is that we will do it again.
I think another message, Bjorn, absolutely, we will do it again. And we want to thank everyone who's stayed with us, and certainly the people that tuned in early. If depending on your time zones, it's been a little bit of a challenge to meet everybody's needs here. But again, this is recorded, and you will be receiving a recording.
Yeah, absolutely.
I think what's left me with the greatest inspiration is that is how the healthcare community and the simulation community has adapted to what is really a new world order, right? It's forced change, and the people we've listened to this morning have all in some way contributed to our ability to adapt to that new world and make
Absolutely.
it work so that we're on the offense and not on the defense, right?
Yeah, absolutely, absolutely. So I just want to reach out to everyone now and make sure that you have understood that you will receive an email, which will direct you to where you can find on-demand recordings of the whole conference today. And that you should be sure to check out the COVID-19 Resource Center, which we have available, where you will find links to free simulation training scenarios, checklists, research, and much more. And we encourage you to reach out to our local Laerdal representatives around the world after this conference if you have any additional questions that you might want to ask. Although COVID-19 prevents us from gathering in person, we are committed to connect to the simulation community and to share our best practice for simulation training and to learn from those who have been in the trenches during this crisis. So stay on the lookout for additional webinars and virtual Sun conferences coming your way from us. I just want to, before we just end and go to our CIO for a last message, I just want to thank Andrew Kristofic, my co-presenter from US, for a fabulous job, and also Sean Feenley, who is also part of the American team. Esme Davis and Kevin Sterling from the UK team, who has also been instrumental in helping us putting this together. Yun Tolo and Matthew Chon Lee, who are in the studio right now, making sure everything works. And Darlene Giornado and Vaios Arkanotis, sorry, he's Greek, who has helped us managing the Q&A stream. Thank you very much. My name is Björn Egeland. I hope to see you soon.
Thanks, everyone.
We hope you've learned something valuable today and that you've been inspired by the experiences of our community of simulation experts from around the world. We still have a lot to understand about COVID-19. But we hope that as we learn more, we will find solutions to improve patient safety while also keeping healthcare workers safe. We hope that sharing experiences during this time will help us to better be prepared for the next pandemic when it arises, because it will, and we need to be ready. Please take the opportunity to continue to share, learn, and to inspire each other by joining the Facebook group we have established. It's through this type of global collaboration that we will be able to help save more lives together.